when we are able to see that even BRCA1, BRCA2 gene, which were a horror a few years back for every patient who got diagnosed, now we have a targeted treatment available for it. So our role as a molecular pathologist in molecular oncology has risen in a very, very, amicable manner. And I think the knowledge which is available today and the application of it in the clinical practice, it's amazing. I see different cancers every day here in Kokilaben, and I see that so many molecular markers, different molecular markers, even in the breast. Metaplastic has different molecular markers. Sometimes I do not get the markers. Sometimes I wonder what happened with the patient. Sometimes I do get some very rare variants, and I do look into the pathogenesis and try to see if a combination of two different molecules can help the patient. So it's a science we are learning every day. And the best part is it is helping patients. Patients are getting better. There was a time when there was only one drug, chemotherapeutic drugs, combination of different for squamous and different for adeno. But now, based on the molecular markers, we are able to treat them in a unique fashion based on each person's genomic data, and which is known as a personalized medicine or a precision oncology. So this fascinates us. This keeps me awake day and night, and it really motivates me to do better for the patients. Thank you, sir, for the introduction. And before wasting any more time, I think I would love to start my talk, and I can take any questions in between if anybody wants to talk to me and interrupt. So I'll just put up my slide section here, and then we can take it from there. Just a second. I think
Do you have the sharing right, Amrit?
Yes, I have my PowerPoint open, but I'm not able to share.
Madam, there is a
Can you choose? Yeah, people.
there is a square-shaped one below the Google Meet with an arrow. You have to click that the PPT.
Yes, it's coming.
Are you able to see
it's
now?
coming. Yes.
Yep. Thank you. Thank you so much. So getting back to the topic again. So today we will talk about advances in molecular pathology and emerging tissue biomarkers in precision oncology. Yes, please.
Excuse me, ma'am. PPT is not being shown now. Your desktop is being shown.
Screen is being what is seen. Yeah.
It's a Chrome. It's in the
screen.
Chrome mode.
PPT is not being seen now?
No, ma'am.
No, ma'am.
Just a second. How is it now?
Yeah, yes, it's being shown.
Yep.
Okay, ma'am.
All right. So without wasting any more time, so let's get back to our topic, which is definitely. I've tried to make it, interesting in a simplified form, and let's get into the different organ systems. And before that, I will just introduce what is genomics and personalized medicine. What are the guidelines for molecular testing? And I have 4 to 5 different cases which can help us to understand why molecular testing is important. And it's very important to understand what patients require molecular testing, whether this patient needs a single gene testing or this patient needs a series of 500 gene panel or a 50 gene panel. So it's very important as a molecular pathologist to understand at what type of disease that we are dealing with and what type of information we are looking out after these molecular techniques. Then I will just touch upon the liquid biopsy, a need for the liquid biopsy versus the tissue biopsy. And then I will summarize my talk. So this was one article which I have, written in
Dr.
2022. Yes.
I think your screen is not full screen, and your slides are not moving.
Is it now, ma'am?
Not yet.
No. So
No.
what I'll do is I'll keep it like this so that you're able to see. How is it now? Are you able to see my screen now?
Yeah, we can see your screen, but it's not full screen. Yeah, it's the third slide.
Yes, ma'am. Yes, ma'am. Let's keep it like that because then if it's a problem with the movement, then
Okay.
this might be helpful. So this is one article in which the role of a pathologist. Now we call it as a next generation pathologist. This was an article 2 years back, in which in the next era of molecular oncology, we wanted to define the role of a pathologist, but now we have become a next generation pathologist because we are able to guide the clinicians the type of treatment that can be used in different scenarios in different patients at different timelines. So this is, the evolution of the pathologist has happened. So this is something very important, something very fascinating. So I'll start with the basic Robbins chapter. We remember that we used to read that there are 8 or 10, hallmarks of cancer, but now we have moved on to 14 hallmarks of cancer. The cancer has been studied very extensively, in terms of different parameters like the growth suppressors, and now recently the polymorphic microbiomes also has been entered into the pathogenesis of the cancer. So from these 14 hallmarks of cancer, we still have some clinical challenges. We still have a lot of milestones. We want to understand the early detection. We want to know what is the type of the disease and what is its subtype, not only histopathologically, we want to know the molecular subtype. Now we want to decide on the tailored novel treatments of every patient, personalized to every patient. And we also want to understand the benefit from these treatments. So then the deliverables also are quite challenging. We want to understand the prognosis. We want to monitor the disease, monitor the effect of the chemotherapy or the targeted therapy. We want to improve the survival, and we also want to improve the patient's quality of life, which is equally important to the patient. But the challenges on a histopathology are again quite obvious. There's a heterogeneity which we see, and then there's a heterogeneity in between the same clone. Also, there are 2 different types of mutations. The microenvironment is also something which is very, very particular, that whether the microenvironment is supportive towards the cancer or it is supportive towards the patient. Then we have to know the metastasis, to what point it is metastasizing, whether it's a brain or whether it's a pancreas or the bone, and the toxicity levels of the targeted and the chemotherapy, or whether we are seeing the resistance, and resistance at what level we are seeing. And then we also now want to know the hereditary part of the disease that we are dealing with. So these are the clinical challenges in the cancer. But then when we look at the diagnosis, the challenges of the diagnosis, we see that there are so many actionable genetic alterations which are coming up. Lung definitely has quite a number of definable, actionable markers. Then we have a pan-cancer biomarkers like MSI, which has been established, and NTRK, TMB, now MET, and all those markers which are available, which are positive in all sorts of cancers. Then we have a clinical trial data which shows results, and we want to understand whether that results are applicable to the Indian scenario or not, or they're just applicable to the outside patients. Or we also want our patients to get into those trials and understand the effect on our genomic data. So like this, we have evidences, and then we have challenges also that we have already discussed. So instead of a multiple, iterative test, the lab needs to have, the test which might help the patient, in a better way, rather than going from one gene to the next gene. So I will discuss all those things. But before that, I think the heterogeneity is something which is, I thought the budding pathologist should know, that in response to the chemotherapy, the resistant clones develop, and these are the ones which progresses further. So what is personalized medicine? On the average, we have, ma'am, are you able to see my slides?
Yes, we can.
Okay. So 40 to 50% of the patients, they first, it was like organ specific. If it's like liver cancer, this treatment. If it's like a lung cancer, it was definitely this type of chemotherapy we used to use. But now the options of the treatment, have increased based on the targeted therapy, hormonal therapy, and then immunotherapy has come up, which is life changing for the patients. Then obviously radiation therapy has been there, in ages. So when we look at the chart, how it has grown, now we have around molecular signatures which are responsible, and the treatments are available for that. So 73% of the oncology drugs in development are the personalized medicines. I'm sure this is a year-old data, but this reality is that the increase in targeted treatment, therapy has increased from 6 to 13%, which has reduced the cost of the patient for using chemotherapeutic drugs quite a lot. So that is something very, very helpful. And then the chances of adverse effects which happens with the usage of chemotherapy has also reduced down. And then the increase in clinical trial eligibility has increased. So there is definitely a hope which is coming up out of this precision oncology. And if we look at the treatment FDA approved drugs that we see here, so we see a lot of them have approved and they have given us results. And then we have a tyrosine kinase inhibitors, how they have, evolved throughout, in this last 10 to 15 years. Then we have some combination drugs which has been approved for different cancers. And that is also something commendable in the treatment of the history of oncology. So before I get into the cases, I just wanted to explain what do you mean by immune checkpoint inhibitors and what is immunotherapy. So when it is a normal misnomer that, why when we are looking at a bacterial infection or viral infection in a person's body, the body's lymphocytes or the body's immune system is able to fight against those bacteria and virus. And then the question is why they are not able to fight against the cancer cells. So there was a lot of science which came into picture, and we found that the cancer cells or the tumor cells, they express the PD-L1 receptor on the surface. So because of this PD-L1 receptor, the immune cells are not able to bind to the cancer cells, and then they are not able to destroy or kill the cancer cells. So with the result, the immune checkpoint inhibitors came into picture, in which we were able to bind to that PD-L1 receptor on the cancer cells, and then the T cells or the B cells were able to, T cells were able to, kill those cancer cells, and then the response to this therapy was quite amazing. That it helped a lot of patients, and it has been seen in different cancers. So as a pathologist, when we look at a slide, and if I want to grade the tumor infiltrating lymphocytes, this is amazing. Sometimes which we see, I think all pathologists, we see the lymphocytes getting inside the tumor cells, and we see some of them around the tumor cells, and then some of them are almost killing the cancer cells. So that is something very, very visually. It gives us a lot of pleasure to see that how these immune cells are actually working. So when I look at different same type of cancers. We see in the left side low-grade TILs, we see a lot of fibrosis and hyalinosis with the tumor cells, but very few lymphocytes here and there scattered. So this is probably the type of cancer which will not respond to immunotherapy. So as a pathologist, we can just give them information. It's a low TILs, so immunotherapy probably might not work. So there are some other immune markers like MSI, TMB, and PDL1 positivity, which helps us to understand whether the immunotherapy will work or not. But we as a pathologist, if we look at the slide, we can say that this in this particular low grade, it might not work. But when we look at this intermediate grade TILs, you see they are in between the tumor islands. They are in between the tumor islands. They haven't gone inside the tumor island. So this is intermediate grade. So this probably will give us a partial response. So, and when you look at a high grade, the immune cells are everywhere. And in this cases, the response to immunotherapy will be probably very good. So we can actually guide the clinicians that, yes, this is the point where, yes, you can go ahead and do the work if other markers are negative. If you get a PDL1 less, in this high grade, you will get a high PDL1, but if you do get an intermediate grade PDL1 low, you probably might be able to guide the clinician, yes, you can go ahead with immunotherapy. So this is very good representation in which the left side, there is no CD8 cells. They're absent from the periphery and inside the tumor cells. In this, they are on the side. This is known as excluded. So this is the category which has been defined: desert, excluded, and inflamed. So inflamed are the ones which gives a good response to the immunotherapy. And this has been proved quite well in cases of melanoma, that if you get a good TILs, and definitely the response is pretty good. So now the oncologists are on the way, that whether we should go for chemo or we should go for immunotherapy. And I think there's another one category, targeted therapy. So it's quite fascinating to all of us. So when we look at a different tumors, I think the multidisciplinary approach becomes very, very important. So the oncologist, the molecular pathologist, the radiotherapist, everybody needs to sit together and decide which pathway is activated and how we are going to approach this particular case. So I think the molecular tumor boards are picking up in every hospital, and we are talking, how we are talking on every case to understand that how to approach different cases. So before I get into the further, I wanted the pathologist, a young pathologist, to understand what do you mean by a driver mutation and what do you mean by a passenger mutation. When we talk about driver mutation, we say this is the mutation which is responsible for the cancer. This is the one which is driving the cancer, and this is the one which is responsible for, probably metastasis and infiltration into the surrounding tissues. But when we talk about the passenger mutations, these are the mutations which are normally seen. Maybe probably after 50 years, you see some passenger mutations like a chip mutations, which are present in the body. They do not cause the cancer, but they're silently present. But probably they can give rise, if there is some other mutation, to some driver mutation. But passenger mutations are usually, lying silently in the body. But the driver mutation is something which we need to look into. And again, that depends upon the VAF, variant allele frequency. How do you define the driver mutations? And this is probably applicable to the somatic mutations because they are non-inheritable, and you can measure them by the next-gen sequencing. And then when we talk about the germline mutations, these are probably we inherit from the parents and we pass it on to our next generations. And sometimes 95% it is like that, but 5% you can have a de novo mutations, and the person can acquire mutations when the patient is still in in the blastocyst stage. So it is important to understand the germline mutation because first of all, we risk predisposition is important, because if the patient is having a germline mutation, the chances of getting a cancer is around 50 to 60%, 40 to 60%, depending upon the type of the mutation we have. But if you don't have a germline mutation, obviously the risk becomes to 1 to 5%. So it is important to understand because, it also gives an information on the reoccurrence, whether the patient might have some other cancer some other time as well. And monitoring and surveillance definitely it becomes important. Now, how does the things are approached nowadays in our hospital? I would like to say, so when there's a clinician referral, whether it is a somatic or a germline, the patient comes to us. So we look into the complete medical history, whether it was a first time, whether it was a relapse, or whether it is the one cancer has been cured and the second cancer has come up. So we look into the complete medical history. We decide whether the patient needs, if it is a therapy resistance, what type of panel the patient wants, and then depending upon that, we take the consent for the patient only in germlines, and then we take the sample or the tissue if it is required, and then we run the sample on next-gen sequencing or on single mutation based on the type of history of the patient, and then we interpret the reports, and then we call the patient for the post-test counseling. So in germline, definitely we offer them surveillance and the management, like some preventive surgeries. In somatic, we offer them that these are the treatments which are available, and then we refer them back to the oncologist for the treatment. So what is the use of next-gen sequencing? You give the diagnosis, you find the treatment response, you measure the disease in the form of MRD, and you also look into acquired resistances if that happens. So I've taken up few cases. Let's go one by one. I hope I will be able to explain that how the next gen has been helpful to us. So when we look at the evolution of the lung cancer, we see that how we have evolved. First, we just wanted to know it's a non-small cell or a small cell. But then gradually, we wanted to know whether this is an adenocarcinoma or a squamous cell carcinoma. And then because the treatment was definitely different, and in the mid 2008 or 9, we identified we have an EGFR and ALK mutations, and TKIs can also be given. But now we have a whole lot of new mutations, actionable mutations, which has come up. So on the histological subtyping, we are very sure that if it is TTF1 positive, it's adenocarcinoma. If it's P40, it is a squamous cell carcinoma. So after defining that, we also look into the NETs, which include carcinoids, typical and atypical, small cell and large cell neuroendocrine tumors. And now we have a sarcomatoid tumors also. But all of them, they are, even after the diagnosis, we have definitely defined mutations, which are, particular to that sort of cancers. But then, there are a few of the actionable mutations, which is important because this is what targeted therapy is all about. So in 2021, we had these genes, which the NCCN said, if it is an adenocarcinoma or a squamous cell, you should, in the advanced or in a locally advanced or advanced or a metastatic stage, you should screen every lung cancer patient for these mutations because we have a targeted treatment available for these patients. So this was something very, very advanced and very, very revolutionary, that the lung cancer could be, can be treated. And I don't know, surprisingly, the Asian population, if it's like females, non-smokers, and young age adenocarcinomas, they seem to have more of a driver mutations as compared to the Western population. So I just had a recent talk on the difference in the type of mutations in the Western and the Indian or in the Asian scenario. So definitely we had EGFR much more higher in what do you say, the statistics was much more higher in Indian scenario or the Asian scenario as compared to the Western population. So when I looked into that particular paper, even there's a difference in the mutation in the Western India and even in the Northern India. So KRAS was something again on the higher side in the Western population, and EGFR was higher in the Western India, while in the Northern India, ALK was higher. So this was a very good comparative study we had in TMH recently, which was quite mind-blowing because we didn't know that the statistics differed between the Western and the Northern India. So I'll get back to the case one. I have two cases for lung cancers just to discuss two different scenarios, just to make the pathologist, junior pathologist understand when to give what type of tests. So this is a 68-year-old male, and PET CT showed infrahyomas, already metastasis to the bones. So the histopathology came as non-small cell lung cancer, and it was diagnosed as spindle cell carcinoma. So this was around 2 years back, and that time I think only EGFR Alcross and Alcross, EGFR Alcross in our hospital was established to be done on every case, not all the 11 genes which are recommended. So all were negative, while the TPS score was 70 to 80%. As usual, it's very diagnostic. The patient needs a chemo plus immunotherapy since it is already metastasized. So 6 months later, he came back again with the pleural effusion. So we ran the whole big panel, and we got a MET exon 14 skipping mutation, which is quite rare. But I think probably more testing is required in Indian population to understand the true statistics, because many of our patients we are not able to afford, or probably many of us do not know that we need to go further on all the cancer genes that is required. We need to screen for all the 11 cancer genes. So, but if this patient comes to me another after, in a metastatic stage, I think bigger panel for 500 gene panel will be much more helpful. So we all know that cabozantinib is a very good targeted therapy which is available, and the PFS is 24.6 months, and ORR is 24 as compared to 8.1 months if we do not give them MET inhibitors. So what do you mean by reflex testing? Before it was like you do EGFR, and if EGFR comes out negative, you go for ALK. And if ALK comes out negative, you go for ROS. This was how the reflex testing was. But now I suggest another reflex testing. And what is that? So in this case number 2, we have a EGFR exon 19 positive cancer, this patient, and he was on EGFR inhibitor therapy, probably gefitinib. And then he showed a progression of the disease, and the ctDNA was sent to us to understand if there is a 2790 mutation. And we got the T790 mutation, but we also ran the sample, for the amplification, the bigger panel around 50-60 genes, and we also got a MET amplification in this particular case. So this is reflex. If you get an exon 19 mutation positive, if there's a resistance, we immediately do the next gen sequencing to understand what is the cause of the resistance in this particular case. So the patient was started on osimertinib in this case. So this is a beautiful table in which this is the first gen gefitinib, and gefitinib is second gen, and then afitinib, and then osimertinib. So we can see how many different clones appear and how they cause the resistance. So this was an old thing in which EGFR Alcross was done, but now we have completely converted into a 11 gene panel in Kokilaben. We have a panel of 11 genes in which we screen every lung cancer panel in advanced setting, either it is local or advanced or metastatic, and we put the patient for all the 11 genes, and then we start treating the patient. And now if the patient comes back later, resistance to these, then we run for a bigger panel to understand the mechanism of resistance, in which you can see aberrant expression, aberrant pathways activation, whether this is a MET amplification, HER2 amplification, EGFR, other FGFR signaling pathway, or AXL activation, or there's a downstream pathway activation, or there's a histological transformation even to small cell lung cancers, or there are other mechanisms which are responsible for resistance. So then this is a beautiful article in which the different combinations of mutations are also present and how they can affect your treatment. So this can be another topic one day. So it's very important to know whether we should go for a tissue or a liquid biopsy. Tissue, definitely it's a better diagnostic in which you will get the proper clone. But the heterogeneity is something which we see only in liquid biopsy. So we might get a driver mutation in tissue biopsy, and we might get a more heterogeneity in the liquid biopsy. So sensitivity and specificity is higher in tissue as usual, but liquid biopsy is used mostly for monitoring, and sometimes when we are not able to get the appropriate amount of tissue for running the NGS testing. So that is why when they say when you get a histopathology diagnosis based on TTFR or P40 and P60, don't waste the tissue on single testing. Just run the whole panel and see what we are dealing with, because tissue loss is something, sometimes we cannot afford, and the patient is not willing to go do a biopsy again. So, sorry, next is cholangiocarcinoma. And again, cholangiocarcinomas, we know that is intrahepatic and extrahepatic based on the site of origin, and there are different mutations which are responsible for the pathogenesis. Now, if we look at the genomic profiling and if we look into the approvals, FDA approvals, they are pretty good. FGFR2, cholangiocarcinoma was once like unoperable and how to treat the patient. And now we have so many targetable mutations which are present. And if we treat the patient based on biomarkers, we definitely have a better OS, overall survival, as compared to the patients not getting the targeted treatment. So the next is prostate cancer. Prostate cancer is, again, we know how it goes about from initiation to progression. It goes from PIN to adenocarcinoma, latent, and then clinical, and then metastasis. And down we see there are so many genes which get activated at different levels, and together they causes the activation of cancer, and it is then leading to metastasis. But as we see the treatment evolution, the FDA has approved a number of hormonal treatments, a number of hormonal treatments for first generation, second generation, third and fourth generation for the treatment of these prostate cancers. But now, there is evolution in the molecular markers, which I would like to discuss in the next two cases. So we had this case of metastatic prostatic cancer. He presented with the mets to the bone in the liver, and then he was started on Abitron as usual for the hormonal treatment. Then again, within 6 months, he had another spine met, and then obviously he's not getting treated with the hormonal treatment, so we label the patient as castration-resistant prostate cancer. We ran the 500 gene panel, and we saw that there was a KRAS mutation, 41% VAF. It's quite high, so this is definitely which is causing the resistance. ERK2 mutation. So yes, it has been given approval in other cancers, but not in prostatic cancers. But the HRR panel was run again, and we found that CHEK2 mutation was positive. So when the CHEK2 mutation, 43%, so the patient was definitely eligible for olaparib and rucaparib. And then we run the germline on that patient, and he was found to be positive for that CHEK2 mutation. So this was a very good, this was an African patient, and now he is doing very well. International patient for us, he's doing very well on this. So the frequency, if we look at the HRR genes in prostatic cancer, we see that ATM is quite common, CDK12 is common, and CHEK2 is 2 to 4%, but we need to screen every patient. Why? We don't know what is the exact number, what is the exact frequency, unless and until we screen it. So, so many patients, sometimes they sit to us and they say, if nothing comes out, why should I waste 1 lakh or 1.5 lakh? The only reason I give it to them is, but if you get that lottery, if you get that driver mutation, or if you get that biomarker positive, aapki to lottery lag jayegi. So it's like sometimes, even though the percentage of cancers getting the positive mutations are lesser, but sometimes when you get it, you're able to treat the patient, and this patient is doing really well 2.5 years post-treatment. So what is the significance? It gives a prognosis. good prognosis. Hereditary risk, yes. Treatment decisions, yes. And if there is eligibility of clinical trials, yes. So it's good. So these are the HRDs. They are basically to repair the double-stranded pathways. So I think I will discuss a little bit about it in the ovarian cancer thing. The message here is NCCN guideline has clearly stated that if you have an advanced or a metastatic cancer, you have to undergo a HRR testing and you have to undergo a germline testing in every patient. So this is the guideline. So we have to start following it, start implementing. We as a pathologist, we need to write a note after every report that yes, it is a prostatic adenocarcinoma and lymph nodes positive, and maybe the urethra is positive, it is advanced and advised, HRR testing, advised germline testing for this particular case, depending upon the family history. So we as a pathologist, we have to push this precision oncology forward so that many patients, they start getting benefited out of it. So NCCN guidelines clearly say if you have an ovarian, breast, pancreatic, and prostatic cancer, undergo a germline testing. And tumor testing, yes, ovarian, pancreatic, and prostatic cancer. So this is a beautiful diagram, which I really like. So in this, the elephant is the cancer, and we are trying to understand how to act on this cancer, whether you should do the genomics or proteomics or microbiomics or transcriptomics. So we are all trying in a different ways to target this cancer cell to help the patient. So this is quite interesting. So let's go to the next case. I think this is a breast case. This is a 43-year-old lady with a bone metastasis and histopathology diagnosis in invasive ductal carcinoma. ER was positive, PR weakly positive, and she was started on tamoxifen, but also, yes, the chemotherapy was given because the tumor burden was high. So then 2 years later, reoccurrence happened, and we did run a liquid biopsy on this particular case. And to our surprise, she had a high TMB, which is good, and she's a candidate for immunotherapy. She had a BRCA2, very surprisingly, 28.3%, looks like a somatic mutation. And she also had a PIK3 mutation, 1.7%. Now the question, PP53 as usual, so nothing much to think about. So now the question was whether to start the patient on immunotherapy or PARP inhibitors, or whether we should start the patient on alpelisib. Now, if you look at the VAFs, obviously alpelisib doesn't look like a good option here. The option is to choose between the PARP inhibitors and the immunotherapy. So when we looked at the trials, ER positive cases, we have alpelisib and letrozole has given us a good results. But then we see that PARP inhibitors are also quite a good they give us good results. So we diagnose the patient as BRCA1 mutation positive breast cancer. We can start the patient on platinum therapy. That was our recommendation from the molecular pathologist. Because if the patient is BRCA1 or BRCA2 positive, platinum therapies works very well, and also the PARP inhibitors works very well. So the patient was not, wanting to go for immunotherapy because of the cost. So the patient was started on PARP inhibitors, and alpelisib was not started at this point. So if it is a breast cancer, definitely a genetic counseling to look out for the hereditary mutations is important. The inheritance, the family history is definitely important, so that we can help the others, maybe the siblings, maybe the children, from delaying in getting the cancer, or maybe preventing the cancer to happen. So I think this is something I run a hereditary cancer clinic in Kokilaben, so which is a total pleasure to meet every patient. They have so many questions. The science has come up so vast. So we need, the more you talk about the science, the more the patient feels stabilized. The patient is very fearful when the patient comes in. When I tell them that knowledge is power, it's best that we get the test done, and we have a preventive options. We have the treatment options. This induces a lot of confidence in the patient. And this is what I like to do. And we have a lot of BRCA1 families, TP53 families. And very surprisingly, HRR, that FANC A and FANC B, FANC C, so many diseases which are, we are collecting the families, and they do come to us every 1 year, every 6 months to understand what next needs to be done. So it's quite good. So as a pathologist, we need to push this thing forward so that, it can be implemented into the common practice. So I think I loved this. She was asking, tell me the truth. I'm ready to hear it. He's saying, your NGS has a driver mutation. There is a drug that can save your life. But the sad story is you cannot afford the drug. Neither there's a clinical trial or a compassionate access program. So I think this is just to cheer all of you up so that there's a break in the routine. And now this is I think the last case, a 65-year-old female with the high-grade serous carcinoma stage 4, CA125 is high. So the patient was started on neoadjuvant therapy, and the patient was given, surgery was given, and histopathology showed positivity for all the markers for serous carcinoma. And the NGS was done for this case. And as we know, the serous carcinoma, platinum therapy again works very well. And when we did the NGS, we did get a mutation on P53, ATC, and MYC amplification. So definitely it's a high risk disease. So that's why the patient has presented with the METs, and tumor mutational burden, TMB, was high, intermediate. And then we saw, even though the BRCA1, BRCA2 genes were negative on germline, there was a genomic scar which was high. So HRD status was high. So HRD is something which is already established in ovarian cancers. So we have to look for HRD in a metastatic state because the patient is eligible for olaparib. So this is what I wanted to focus in my last HRR gene, that the body has a inept ability to repair the damage caused by the UV rays, the damage caused by the surroundings, and when that methodology, that repair pathway only is disrupted. When that repair pathway is disrupted, the body is not able to repair those damages. So when the body is not able to repair those damages, there are two things. First, it leads to the cancer formation, as we see in BRCA1 and BRCA2 and other HRR genes. Second is, when the body is not able to repair, the targeted therapy or the platinum therapy is able to break those cells in a very efficient way, because the repair pathway is already defective. So it's not able to repair the defect caused by the chemotherapy and the targeted therapy. So with the result, the patient response is quite good. So that is why HRR and HRD in prostate and ovarian cancer helps us to treat the patient better. So this is something new, recent advance, which I really like to talk about. Now, I think if everyone is awake, then we can talk about the technologies also. Are we ready to listen to that?
Yeah,
Yes,
go
ma'am.
on.
We are all following. Please go ahead.
All right, thank you so much. I think myself and Dr. Nambiar was talking that it's very important to know our technology. Technology and the usage of the technology. So if I am looking at a breast cancer, which is ER, PR positive, HER2 negative. So if I want to start the hormonal therapy on that patient, or if the patient comes later after hormonal therapy with the resistance, I know what I need to look into. I probably need to look into PIK3 and PTEN mutations. So that is the time, if you want to look into only PIK3 mutation, you can probably go on RT-PCR on Sanger. You don't want to, do a bigger panel. So it all depends upon the type of cancer and the clinical scenario that you're dealing with. But if you're looking at a triple negative breast cancer, you probably want to look into first germline. The bigger panel, not only BRCA1 and BRCA2, a bigger panel. And if that comes out to be negative, you should go for a bigger 500 panel for somatic, any targetable mutations. So the approach in different scenarios is different. So this is what, and to understand that part, I think I'll just touch upon the different technologies. Cytogenetics, yes, it is more commonly used for hematological malignancies, but particularly ALL, AML, and sometimes even in CML, that worsens the prognosis. And hyperdiploidy is something which is a good prognosis. Hypodiploidy is something bad prognosis. So this has a specific, limit. It tells you only about the chromosomal abnormalities, particularly the translocations or the bigger deletions, bigger inversions, but it does not give you, it's a very low resolution. It cannot give you more information on terms of mutations, amplifications at a genomic level. It is just at the chromosomal level. So the next one is the FISH. FISH is very specific, gold standard for few of the tests like HER2. It is a gold standard if you want to say if it is an intermediate on IHC 2+, we want to confirm, we go for a FISH testing. It gives you a definite answer. If we look at BCR-ABL on hematological malignancies, if you want to say plus or minus, it's definitely PML RARA. And even in brain tumors, 1p19q, if you want to look at it, FISH is something which we can go ahead and do the testings. So it's all probe based. So we incubate it and we look it under the fluorescence microscope. The next is a PCR. PCR can be qualitative and quantitative. When we talk about qualitative, it just gives you a positive result and a negative result, whether it is present or not present. But if you want to measure the copy numbers of one particular fusion, like BCR-ABL, I want to look into the copy numbers. Patient of CML comes to me and the imatinib, the TKIs has been started, and I want to understand how much the disease is, getting reduced with the help of imatinib. So today, when I start, I have a copy numbers of around, I can say 5,000. So after three months, we properly check those copy numbers. And if it is decreasing 5,000 to 3,000 to 1,000, if it is decreasing, log increased, IS scale is important. If I see the decrease, it means that the disease is working well. So that is known as a quantitative PCR. And these are very, very specific. The probes are Techman probes. They are very specific for that particular fusion, for that particular transcripts, and the sensitivity is very, very high. I think we get a sensitivity of 0.001, and there will be definitely high PC, low PC, or NTC or NC. These are the controls that we run along with it, and we get a very good results. But when I run an EGFR or when I run a JAK2 mutation on my PCR, that will just give me a positive and negative result. So whether exon 19 is present or not, whether exon 18 is present or not, 20 is present or not. But then when I say exon 19 is present, I may not be able to detect a single particular variation of nucleotide variation. I might not be. There may be on that point 5-6 different nucleotide variations that might be present. So this is how there's a limitation of qualitative real-time PCR, qualitative PCR over NGS. So that's why NGS is always better, because it will tell you what particular point mutations that you're looking at. But the real-time PCRs are definitely high sensitivity and high specificity, and I think it works very well for hematological malignancies. So Sanger, I think Sanger should be used. It is a gold standard, definitely, but it is only used for small hotspot mutations. You can't sequence a bigger gene on this. A few exons, 2 to 3 exons with particular, if you just want to confirm a particular mutation which has a NGS VAF of around 20 to 30%. That's what is our cutoff. If it is in a germline, if it is 30% and above, we call it as positive. It comes up in 20 to 30%. You want to confirm it on for the patient, you do it on Sanger. You buy those primers and probes, and then you run it on Sanger and confirm whether that is present or not. So Sanger sequencing has its own limitations, but it is a gold standard. In our laboratory, we use it for JAK12, exon 12, SEPA, MPL, for both solid and hematological malignancies. Fragment analysis is something also very, very good technology. I really like it because it will, quantify the number of base pairs on capillary electrophoresis. So you will be able to detect NPM14 base pair deletion or 20 base pair deletion. Similarly, FLT3. FLT3 has a variation of 30 to 300 base pair deletions. So sometimes you get 30, sometimes you get 100. We have got some cases. So that is something really good. The best part is MSI. MSI, it will tell you about the instability. So we have 5 markers with a star 5 markers. So we try to run them and we say if there is one marker which is unstable, it is a low MSI, it is equivalent to MSS. We don't consider much it as a high instability. But if it is if it 2 and more than 2, we call it as a MSI unstable. And we tell the patient in a colorectal malignancies that if you are in stage 2, you might probably, skip on the chemotherapy. So this is how we tell them. And if it is like MSI high, definitely calls for a screening for the Lynch syndrome. So, and definitely the patient is eligible for immunotherapy. So every test gives you so much of information that we can help the patient. So the next is chimerism and fragment analysis that helps us to measure how much is the graft, acting on the patient from the donor to the patient, and how much, if there is more of a graft from the donor, definitely the graft is happening and the patient is doing well. So these are sometimes very, very interesting technologies. Next is NGS. I think it is a nucleic acid. I think we all know about it. There are 3 different processes: nucleic acid extraction, library preparation, sequencing, and analysis. So I think there is a specific workflow on the technology. If it is like Illumina, it is a double base pair. If it is like, if you're dealing with the iron torrent, it is like single. So Illumina definitely has a better sensitivity and specificity, but it depends. Like, solid tumors, if you're dealing with, you can run on Illumina. If you're dealing with the hematological malignancies, you can run on iron torrent. So this is totally based on the bar coding, specific for each and every library that we do it. And then the QC is very important, whether you use a tape station or you use a bioanalyzer. It's very important to measure your library before you put it in a sequencer. And then the amount of data which is generated is also very, very important. So every panel will tell you how much data needs to be generated. And then you can compare that how much data is generated, how much is a Q30 which has to come out, and then how many reads have been generated. Usually it is 15 million base pairs for my V2 flow cell. So I do keep a check on all the quality parameters. So it's not only about the run, which is important. It is also about each gene. So if a panel has, let's say, 15 genes, so it's not only about the run, which has 10 samples. It's every sample is important. In every sample, every gene coverage is important. Coverage into depth, how much of the reads has been generated. And if you have a hotspot panel, you have to look into every on-site target coverage is important, because we have seen some cases, from outside laboratories in which on-site target coverage was less. I will tell you one story, what has happened. Just give me a minute. So we had a case in which the patient, he was a doctor and he presented with the multiple exostoses everywhere. And he finally came for a surgery because the exostoses were, compressing his nerves in the neck. So he removed that part of, exostosis, that part. And then he came to me and he said, okay, madam, I want to know whether if I have that problem or not, I have a genetic problem or not. So we took the blood sample, we sent it to one XYZ library for laboratory for testing. And then I specifically asked him, I want to know whether EXT1 or EXT2 genes are mutated or not. So when the report came back, on the report, it was written 100% coverage, and then the gene is negative. And I'm like, how is it possible? And then his son came back after 2-3 months, and he also has a similar symptoms. So I knew somebody in that laboratory, and I asked him, just please go and check if it is 100% coverage, because I'm answerable to the patient, what is causing all these different multiple exostosis. He went back and he looked into the data himself. He said that the region exon 12, which has the hotspot mutations, that exon is not covered. So when you're running an NGS, please make sure that it's not only the whole run data, it is the individual patients, individual genes, and the hotspots which need to be covered. So there's a limit. So we say if on-site target is less than 70%, we don't report it. And sometimes I've even gone and seen in that less than 30%, if there is there any hotspot which is missed out? So that is the type of accuracy, that is required in every laboratory to understand that we are not missing on anything, because we are dealing with the patient's lives. So this was also an eye-opener for me, that how the laboratories work and how they don't care. And when I asked him, can you run the patient sample again? And he was like, no, ma'am, you have to pay me for the Sanger sequencing to covering that particular exon, even though he knew that he was wrong. So this is how it happens. We all learn. Then I have ordered the primers now, and I'm running the sample free for that patient. So when you're looking at that, coverage, depth, throughput, WAF is important, which we need to cover up. Look into the bioinformatics, that what type of file is getting generated, FASTQ file, BAM file, VCF file. And when we get the VCF file, we have to know what all variants you need to call, what are clinically significant pertaining to that particular cancer, and what will help the patient in the treatment. So those variants are important. So when we look at targeted NGS, which is used for most of the solid tumors and hematological malignancies, we have other neurological, cardiological, and other disorders, which even childhood disorders, which we are covered in 20,000 genes, which is exome sequencing. And then we have a whole genome sequences, mostly for research purposes, but then sometimes the patient does not fit into the clinical scenario, and then we also go for genome sequencing. Now, this is a new technology which is coming up, optical genome mapping, which looks into the structural variants, amplifications, fusions, and also into the indels. Indels is insertions and deletions, but it does not look into the point mutation. So sometimes they say it can cover up the cytogenetics, FISH, probably fragment analysis, but sometimes NGS and Sanger it doesn't cover. So this technology is being used for hematological malignancies, and it will come up in India very soon. So what I haven't covered is chromosomal microarray that can be used for chromosomes and also for gene, for both the technologies it can cover. So based on the clinical indication, because if you look at neurological disorders, the more of the fragment which we need to look into, so that we have to see whether you want to look into a single nucleotide variation, whether you want to look for a translocation, whether you want to look at an amplification. So that's important. If you want to look into a single nucleotide variation, you probably go for Sanger, you probably go for NGS. If you're looking into amplification, probably you need to go for MLPA. So if you're looking at a fusion, so probably a FISH would be the better option, or NGS also gives you information on that. So every technology has its advantages and indications. So we need to look into the disease first, what we want to look into, and then we look into the technology, what will give us the best answers. So that's how we deal at Kokilaben. So I will just conclude here. So we are into a new generation era. We are looking into novel markers, new markers. We are looking, which are already diagnosed. We are giving answers to the patients based on the biomarkers which has come. We are looking into, agnostic markers, which are very, very important. Does not matter what type of cancer it is, but you screen the cancer patients for all those MSI, NTRK, and all those markers. So you're looking to resistance markers, why the treatment is not working. You're looking for options into immunotherapy. So you're giving a whole lot of hope to the patient. And it honestly, it gives me also hope that yeah, this has come. So, something is possible. If the patient is looking at 6 months, now he probably has 2.5 or 4 years. So that is something which might increase to 10 years. Of course, in lung cancers in EGFR, we are able to see 10 years. We have seen 10 years. So yes, it gives hope. So, and probably we as a molecular pathologist can put in our best to help the patients in a much better fashion. So this is our hospital here, and we sit on a 7th floor, and everybody is welcome. We run a hereditary cancer clinic on 2nd floor, and everybody is welcome to come and have a look at our facility and everything. I hope I have covered a majority of the things, and I'm open to any questions. Thank you.